Right, thank you very much. Good morning, everyone, and a very, very warm welcome to the first ever asthma patient conference. My name is Ratko Djukanovic. I'm the person whose picture is on the screen. I'm an academic respiratory doctor from the United Kingdom and one of the co-founders and co-chairs of SHARP, a European Severe Asthma collaboration, which you'll hear a lot about. It consists of doctors, researchers, pharmaceutical partners, and most important of all, people living with severe asthma. We have a very international audience today, and before we'll start, I'd just like to draw your attention to the simultaneous translation availability, because some of you may not be fluent in English. So you can find the link in the chat box. Just look for the Worldly Translation tool. There it is on the screen. So this will take you to the site where you can choose the language that you want to use, and you read the automated translation alongside the conference page. So the tool uses artificial intelligence to translate the audio. So forgive it if it doesn't get everything exactly right. It won't be perfect, but I think it will help us communicate well. So this is the first time we have run a patient conference focused on severe and difficult to control asthma. The conference was organized as a collaboration between the European Lung Foundation and the clinical research collaboration SHARP. We very much thank the members of the patient and professionals from the conference planning group who spent a lot of time and big effort to organize today's event. So with this brief introduction, I'll hand you over to my co-chair, Olivia Fulton. Olivia, over to you.
Good morning. Thank you, Ratko. Yes, so as Ratko said, my name's Olivia and I'm from Edinburgh in Scotland. I actually have severe asthma myself and have been a member of the European Lung Foundation Asthma Patient Advisory Group, or PAG, since 2006, and then in 2020 became the patient co-chair of SHARP, which Ratko's mentioned already. So I've had severe asthma all my life, and I've been really frustrated with the lack of sort of progress and understanding there has been around the condition, and that's why I've become more and more involved in research and awareness of the condition and trying to make people understand what it's really like, because it's not an easy journey to be on. So over the years, my involvement steadily grew and started out as an awareness video, and now here I am as patient co-chair of SHARP and co-chairing the conference today. So a quick summary of events for today. Because there's no one size fits all for managing severe asthma, and there has been sort of improvements, but not everyone is aware of these improvements. So today what we're going to do is go over a quick sort of severe asthma 101. Then we'll look at sort of self-management, different treatments available, and also what research is being done and how you yourselves as patients can get involved with some of this. Today won't only be about sort of experts speaking who work in the profession, but it will be about hearing from people with lived experience, which is really key, because there's often so many times you want to ask questions that clinicians don't know how to answer, and it's actually your fellow patients that know best through their own experience. So what I would do is encourage you to get the most out of today is use the chat and the question and answer box. Thank you for putting the slide up just now. So you'll see just now there is the chat slide. You can communicate with each other, say where you're joining from, if you want to share if you're a patient or from an organization. And then we have there's the question and answer box as well, where you can put your Q&As in, and they will be answered at the end of sort of each little segment. If there's a question that you particularly like and want to sort of see, then please use the little thumbs up button, because that'll sort of make us aware that this is a key question that people want to know the answer to. So I'd now like to hand over to introduce Kjeld, who is the current chair of the European Lung Foundation. So Kjeld.
Thank you so much, Olivia. So my name is Kjeld Hansen, and I'm the chair of the European Lung Foundation. And I would like to warmly welcome everyone who's joining us today, and also to all the speakers, both patients and researchers. This is something I've been looking forward to in particular, because I myself is also a patient living with severe asthma. And I have this seminar particularly close to my heart. It is the highlight of my year so far. It's easy to say in the beginning of the year, but I think it's going to be really spectacular. So I am currently living in Norway, but I am a Danish citizen, and I've then been chairing ELF for the past couple of years and will hand over the organization the coming September. I'm pleased to let you know that today we have a really international audience. So we have nearly 500 registrations, and you're all coming from around 66 different countries. So 44% are living with severe asthma, and almost the same size of the people joining the seminar are healthcare professionals or medical students, and then we have a smaller representation then of patient organizations, representations, and the general public. So this is truly an interesting audience, and I really look forward to following both the presentations and the interactions in the chat box and in the Q&A. So very warm welcome, and have lots of fun at today's event. Now I'll hand back to Ratko.
Can't hear you, Ratko.
Kjeld's still spotlighted.
Okay, I'm back. Sorry, somehow I slipped into the back room. So let me just briefly outline how we're going to do the sessions today. So please note that you can access the program also on the website of the European Lung Foundation. There'll be a link in the chat will be placed. So there are four main sessions. Olivia and I will jointly chair these sessions, and we'll introduce the speakers. We'll keep track of time, so I'm asking the speakers to please stick to the allocated time. We'll also coordinate the questions to ask at the end of the session. So there's time allocated for questions and answers after each session. And it would be impractical to have questions posed verbally. So please put your questions into the Q&A box at the bottom of the screen as we go along. So the first session is on the basis of severe asthma, as it is very important for us to understand what it is and how it can affect you. And then after a 15-minute break, the second session will cover living with severe asthma, self-management, and getting the most out of your care. We'll then, of course, have a little break, 45-minute lunch break before coming to session 3, which will be focused on how to choose the right treatment for each person, something that we call personalized medicine. And there'll be consideration of special circumstances, such as severe asthma and how you cope with it during pregnancy. The final session will cover future research and new treatments. So I know we're all keen to get started, and I hope my instructions are helpful. So just final housekeeping notes. So the webinar style event is such that attendees can only see speakers. So now you can see only me. We can't see all of you, so don't worry about how you look. You can sip your coffee. Do not smoke because it isn't healthy for you, but otherwise you can do anything you want. So all participants are muted. We can't hear you, but you can, as I said, you can participate in the chat line. You can talk to one another and through Q&A when we invite you to do so. So if you're on social media, please do post about this event and share your thoughts. This is all organized for you, so please take full advantage of it. Tag the European Lung Foundation in your posts, and you can use the hashtag Severe Asthma 2023. The event is recorded, and talks will be made available on the European Lung Foundation YouTube channel, as well as on the ERS respiratory channel. After the event, of course, and others can freely access them. So you can send and share the link to whoever you want. So final point in the Q&A, the question and answers box, which is at the bottom of your screen. Write all your questions again in those. So we have two doctors, Rupert Jones and ELF Severe, who will be helping us to answer your questions, and we'll try to answer as many as we can. Of course, we're limited by the time, so please don't feel offended. We'll try our level best to respond to all. So those not answered, we will try to do this after the event, and we'll put the our answers on the website. So I think this just remains to me to ask now Claire to do a poll. So there will be several polls in which we'll be asking you to participate in. So we'll try one now. So Claire, could you? So you can see here, what is your favorite season? Of course, this is, well, it does have relevance to asthma. And you can click on that, and yeah, we'll take it from there. Okay, so over to Olivia now. So you can see here, there's still a bit of the poll. You can see how people have responded, and of course you can close. Okay.
Oh, is the poll disappearing? There we go. Sorry. Thank you, Ratko. Great pleasure to be able to introduce our first two speakers. We have Dr. Ramesh Kurukularachi from Southampton. He's an associate professor and honorary consultant of respiratory and general medicine and allergy at the University of Southampton. Ramesh has led the original Develop Asthma clinic at Southampton for the last 11 years and developed its multidisciplinary team. After Ramesh's presentation, we're going to have a video from Hannah Nielsen. She lives with severe asthma in Sweden. Unfortunately, she's not able to join us today live. Following both of the talks, we'll have a question and answer session with Ramesh. So make sure you use the question and answer box so we can answer them after Ramesh has spoken. So over to you, Ramesh.
Well, thanks very much, Olivia. I'm just going to try and share my screen. It says you cannot start screen sharing while the other participant is sharing.
You want to try again, Ramesh?
Okay, this looks more promising. Great. Can you see my screen now?
Yes.
Great. Okay. Well, thanks very much indeed, Olivia, and good morning to everybody. It's a real pleasure to give the opening talk in this session, what proves to be hopefully a very interesting meeting indeed. And the purpose of this initial talk is to give you an introduction to the topics that we're going to deal with in more detail through the course of the day. But before I talk in this initial session, I need to pass on my declarations of interest, which I've listed here. But I would draw your attention to the bottom one, which is the most important as far as I'm concerned, because when it comes to talking about asthma, I'm particularly biased because I too have asthma. It's not severe disease by any means, but it still wakes up from time to annoyingly remind me that it hasn't gone away. Now, here is an outline of what I'll be talking about over the next 20 minutes or so, and the various topics that we'll look to cover. We'll start by reflecting a little bit about the burden and the nature of asthma, and then focusing more on the concept of more complex disease, and look at the various definitions that are out there, and try and understand what we mean by the terms like uncontrolled, or difficult to treat, or severe asthma. And then we'll focus particularly on the burden and the nature of severe asthma. Once we've done that, we'll look in more detail at two important principles. The first is that asthma isn't a single disease. It comes in many flavors, and there are many types or subtypes of asthma. And then the other point is that complex asthma very rarely occurs in isolation, and we should stop thinking of people as severe asthmatics, but really as people with a complex combination of health issues very often that come together as what could be regarded as a difficult breathing syndrome. And then we'll move on to look at how we use these new understandings of more complex asthma to assess that in clinical practice, and then try and individualize treatment for the specific patient. And then before the end, we'll pause and consider a question that often comes up in the clinic from patients, which is, why do people develop severe asthma? So how much of a problem is asthma? Well, asthma is a really common chronic respiratory condition, and it affects over 300 million people worldwide. And it's really great that the European Lung Foundation is devoting a day like today to focus on severe asthma, because asthma is particularly common in Europe, and around 6% of people in the European Union are estimated to have asthma. And the rates of asthma vary quite considerably from country to country. And there's one nation here highlighted in red that's no longer technically in the European Union, but it could be considered the sick man of Europe when it comes to asthma, because it has a particularly striking rate of asthma. And asthma places significant burdens, both on the patient and their family, and then on wider society. And we'll hear in Hannah's video shortly about some of those burdens at a patient level, but they include features such as dealing with day-to-day or chronic symptoms, having to take regular medications, the side effects of many of those medications, the risks of acute attacks or exacerbations, as we call them, the increasing dependency sometimes on healthcare providers and systems and carers, and the impact of all of that on work, lifestyle, and quality of life. And then there are burdens for wider society in terms of the costs of providing the medications to treat asthma, and also the healthcare systems to provide day-to-day management or chronic management of asthma, as well as emergency or acute healthcare. And then there is the burden of lost productivity from having a section of society that are hampered by their health from contributing fully to society. So asthma is a big and relevant clinical problem in the modern day. But what is this condition called asthma? Well, asthma is a chronic disease of the airways in the lung, which arises from a combination of complex processes within the walls of those airways. And we can group those processes into four broad categories that you see in the boxes here. There is inflammation, which we've put in red in a big box, which is a major driver of the process. And this can be regarded as an immune process that leads to swelling and almost a sore state in the airways. And then there is airway hyperresponsiveness or overreactivity. So the airways are twitchy and ready to clamp shut at the slightest sort of stimulation. And then there are changes in the airway wall, structural changes that we call remodeling, that we can regard as almost a scarring repair and rebuilding process that stiffens the airways. And then there is excess mucus production. And as a consequence of these four processes, the air passages in the lungs narrow down, as you can see in this cartoon on the left-hand side. So you're breathing through a much tighter airway. And that narrowed airway leads to the classical symptoms of asthma, such as cough, breathlessness, chest tightness, and that typical musical wheezing sound that comes from the airways of people with asthma. And our preventer asthma treatments, like steroid inhalers, target these processes to try and improve asthma control. And of these processes, the one that is paid a lot of attention to is this concept of airway inflammation. And when it comes to airway inflammation in asthma, it has been increasingly characterized as being of a particular type called T2 inflammation. And here the term T2 refers to a process driven by key immune cells called T2 lymphocytes and ILC2 cells in the airway. And they can be regarded as conductors of a really bad inflammatory orchestra within the airways. And this orchestra includes many cellular and molecular players, which I've listed in this table here. And I've highlighted one in particular, the eosinophil, that we will return to in due course, and you'll hear a lot about today, no doubt. And here you see mapped out a scheme by which these members of the T2 inflammatory orchestra link together the various cells and the molecules to lead to the driving features that lead to the clinical features of asthma. And we broadly define asthma as T2 high or T2 low or non-T2. But what we're realizing is that most asthma patients have T2 associated disease. Now, preventer asthma inhalers, as you see at the top of the picture here, like steroid treatments, target that inflammatory T2 orchestra to try and silence it and subdue it and reduce that musical noise of asthma coming from the chest. And healthcare professionals follow these sort of stepwise guidelines. And here we see the international guidelines by GINA. And if you move from left to right, you're moving up a step, the disease is getting more severe. And what we do is we increase the strength and the number of medications. But what is clear is that most people with asthma can get good asthma control with preventer treatments like those steroid inhalers and add-on treatments like long-acting bronchodilators or tube openers. But there is a group who don't. And these are represented at the top level of treatment. But for them now, we have new advanced severe asthma therapies or biologics that target those T2 inflammatory players from that orchestra more precisely. And I've shown this table again to highlight some of those members of the orchestra that can be taken out or taken down by these biologic drugs. Now, when it comes to complex asthma, we're talking about 5 to 20% of all people with asthma. But there is a rather complex set of terms that accompanies the description of complex asthma. So over the next couple of slides, we'll just review the definitions of those. So one definition is of uncontrolled asthma, and this is defined by symptoms as either frequent symptoms, which you see typical sort of symptoms listed here at the bottom of the slide, or frequent asthma attacks, which might need, for instance, rescue treatment with steroid tablets, or perhaps emergency care, admission to hospital. Then, moving on from uncontrolled asthma, there is a broader definition of difficult to treat asthma, which is defined by a combination of symptoms, treatment need, and the wider picture. So here we're saying that difficult to treat asthma is that state that is uncontrolled despite prescribing high doses of inhaled steroids and a second preventer medication, or which only stays well controlled with the use of such high treatment. But I've highlighted in bold a really important point about this definition, because in some cases, the asthma may appear difficult to control because of modifiable factors, things that could actually be readily improved. So for instance, the inhalers may not be taken properly, or prescribed medications may not be taken regularly. There may be behaviors that aren't good for people with asthma, like smoking, that could be modified. And there could be the impact of other conditions, and we call these comorbidities. And then the final definition is of severe asthma itself, which is a narrower definition dictated by treatment need. And here we're really looking at a subset of that difficult to treat group that I defined in the previous slide. And severe asthma is defined as asthma that remains uncontrolled despite treatable factors having been addressed and maximal inhaled therapy being taken, or which again only stays well controlled if those high levels of treatment are being taken. Now, to give you a perspective on the scale of how common these different definitions of more complex asthma are, I've taken information from two very nice European studies that have been published in recent years. So if you take a population of which is everybody with asthma, and you look at that and assess it carefully, you'll find that about 1 in 6 have difficult to treat asthma. And out of that, with further assessment, you will find that about 1 in 5 have severe asthma. So in the population studied in these two research projects, around 4% of all asthma patients were found to have severe asthma. Now, that level of severe asthma amongst asthma people varies from population to population, but generally we would regard that about 10% of people with asthma have a more severe disease. And so what is the burden of that severe disease? Well, we know from our research that it is much commoner in women and that it imposes a significant symptom burden at an individual level. There is a significant treatment burden that goes with that. And alongside that comes the risk of increased treatment-related side effects, particularly historically from steroid tablet medications. There are high healthcare impacts from severe asthma, and the majority of the healthcare costs, the economic impact of asthma, is posed by this small subgroup of people with more severe asthma. So I showed you this burden map, if you like, a few slides back, but just to reflect that most of that burden is borne by people with more severe asthma. Now, we talked about the T2 inflammatory orchestra, and that is particularly relevant to this state of more severe disease. And we know from research that severe asthma is a particularly T2 driven type of disease. So that orchestra is really prominent in more severe disease. And we know that these eosinophil cells, a form of white blood cell, are key T2 players in the orchestra, and they have emerged as core targets for the treatment of severe asthma. And here you see a picture of an eosinophil cell. You can see it's a rather spotty cell, and the spots are what we call granules, which contain a lot of toxic content that drive the processes that drive asthma and the clinical features of asthma. And we know from research published recently that most severe asthma, over 80%, is eosinophil associated and driven. And if we look at the wider members of the T2 inflammatory orchestra, as in this recent paper from our group in Southampton, you can see that almost 100% of people with difficult to treat asthma are what we would call T2 high. And just to remember that we are now moving into an era, time zone, when we have advanced severe asthma therapies or biologics that target those key T2 players, as I've highlighted in red in the table again for you. Now, an important concept to bear in mind when discussing about severe asthma is that asthma comes in many flavors. And that's not surprising because we're all unique individuals, we're all different, but so too is the asthma that we all experience. And asthma is an umbrella term for a diverse collection of states, which may show differences in symptom pattern, attack patterns or exacerbations, and patterns of lung function, and indeed in the underlying associated inflammatory players that are driving it. So we now understand that there are many subtypes, or what we call phenotypes of asthma, but also that if we can find out what someone's phenotype is, that could support us in more personalized treatment to get them as well as possible. And you'll hear a lot about the term phenotype when it comes to talking about severe asthma. And the term phenotype really reflects this concept of what we look like based on our observable characteristics, which reflect an interaction of the genes that we've inherited from our parents and the world or the environment that we live in. And we can define severe or difficult to treat asthma phenotypes in many ways. For instance, according to the age of asthma onset, early versus late may show different clinical patterns. Similarly, males or females may show different clinical patterns, and we may see different clinical patterns based on the clinical features of the disease. So the pattern of airway inflammation, T2 or non-T2, eosinophil or non-eosinophil, or features such as fungal allergy or aspirin sensitivity. And then the other conditions that people with severe asthma experience may also create their own subtypes or phenotype of disease. For instance, there is a concept of obese difficult asthma, and different asthma phenotypes can need specific treatment approaches. So that's a really important concept to be aware of. But so too is the fact that when it comes to asthma and severe asthma or more complex asthma, it almost never is asthma in isolation. So this concept of somebody simply being a severe asthmatic is all wrong. So to illustrate that point, imagine that you're me sitting in a clinic seeing a new patient, and they have a label of severe asthma. So we start to assess what's going on, and very rapidly what we start to find is a much wider picture. So we may find that they're allergic or atopic, but they have a particular pattern of airway inflammation. We might define them as T2 high or T2 low. We might define them by the pattern of their poor lung function, and particularly if they have a form of disease called small airways disease. They may have other particular features of asthma, such as fungal allergy, and then they may show other parallel lung conditions like bronchiectasis or COPD. Just because they have asthma doesn't mean they can't have other things that also affect their breathing. They may have other factors that affect their asthma, like aspirin sensitivity or sulfite sensitivity, and then they may have various comorbidities or other conditions, for instance, nasal disease or rhinitis, breathing pattern disorder, also known as dysfunctional breathing, inducible laryngeal obstruction, also known as vocal cord dysfunction. They may have gastroesophageal reflux disease, GORD or GERD, depending on where you come from. They may have obesity. They may be unfit. They may have psychological comorbidity. They may not be doing some things quite as well as they could, for instance, taking their medications, so non-adherence may be an issue. And they may be doing some things that they shouldn't be doing, like smoking. And then their job might be relevant. And you put that all together and you can see that rather than just being somebody with a label of severe asthma, they are somebody with a much wider range of conditions that all need to be considered. And that's what we call a difficult breathing syndrome. So that leads to a rather complex clinical picture. So how do we approach that in clinical practice when we, for instance, assess a patient with severe asthma? So I think the key is to keep it simple and follow a structured approach. And here you see that the mental checklist that I use when I see a new patient in the asthma clinic. So the first thing I ask myself is this all asthma? If it is asthma, what is the subtype or phenotype? If it is asthma, is the right treatment being prescribed? And if the right treatment is prescribed, is it being taken correctly? And then I'll consider, are the symptoms that I'm hearing about out of proportion to that expected from this patient's subtype of asthma? And if so, what else is going on? What are the additional comorbidities, these other conditions that might be affecting their health state? I'll consider whether a multidisciplinary team approach is necessary. And to be honest with you, my answer to that in almost every case is yes. And then I would create a personalized characterization for the individual patient so that we might tailor their treatment to their individual need. And for that, we would follow a stepwise plan. And I've shown you here a typical stepwise guideline, again, the GINA guidelines. But following that, we would ensure best prescribing, get them on the right treatment, and then work with them to ensure good adherence to treatment, and then empower them to approach this disease and try and take control. So giving them tips on how to optimally take inhalers and educating them about the condition so that they really understand what they're dealing with and how they can take control of the situation. So self-management skills are very important. And they're not only focusing on the asthma, but the other conditions as well, the comorbidities. And then looking at the phenotype or subtype of disease, we would look to see whether there are specific approaches that would be helpful in that individual patient. And if dealing with more complex asthma, I would say if you've got access to a specialist asthma service, that really would be very helpful to engage at an early stage. And here you see a flow chart adapted from the GINA guidelines on how to approach the management of severe asthma, which really summarizes what I've talked about in the last couple of slides. So beginning on the left-hand side with an initial review to confirm the diagnosis, then identify what factors are relevant to that patient's asthma and symptoms, then optimize the treatment, get everything in the right order, and then see how that treatment plan works, reviewing response in about 3 to 6 months' time. And then if needed, adjusting treatment, investigating further, and keeping the multidisciplinary team involved. And then if those first 6 steps do not lead to a significant improvement in this modern era, we can move to the phase of considering these new advanced biologic therapies. And they certainly are transforming the opportunities for a large number of patients with severe asthma. But what I would say is it's important not to ignore these first 6 steps. And there's a really nice paper from the group of Mark Hugh down in Melbourne in Australia, which showed that a thorough multidisciplinary team approach can deliver very significant benefits for a large number of people with more complex asthma without the need for reaching for biologic treatments. Now, when it comes to the biologic treatments, I'm not going to talk in detail about these today. In fact, this is the only slide I'm going to show about it, because you're going to get far more detailed and informative talks on that through the course of the day. But what we are seeing with these biologic drugs is the dawn of a new landscape for us in the ability to treat severe asthma. And what they're doing is offering us the opportunity to silence individual members of that T2 inflammatory orchestra, if you like. And I've listed the common drugs that are now out or coming out in that regard. So we have omalizumab, mepolizumab, reslizumab, benralizumab, dupilumab, and tezepelumab, either widely available or shortly about to become available across Europe, with other drugs in the pipeline in the final stages of research trials. So a really exciting time, and the last decade has certainly seen a transformation in opportunities to offer patients more effective treatments at the severe end of the disease spectrum. But it's important to also recognize that these drugs don't necessarily give complete resolution or recovery for people with severe asthma. There are degrees of response, and there are some people who sadly don't respond to them. So there is a need to evaluate thoroughly, and also to keep doing research to look at new treatment options. Now, one final point that we discussed when we were planning the conference was this concept of why do people develop severe asthma? And it's a really common question that people ask in the clinic. And we don't have a clear answer, to be honest with you. The risk of developing asthma is known to arise from a combination of the genes that we inherit from our parents and the world or the environment in which we live. And we see different patterns of asthma, particularly severe asthma. So in some, severe asthma is severe right from the moment it begins. And in others, it starts as mild asthma and then morphs or migrates into more severe disease. And we know that there are genes, there are over 100 genes that have been associated with asthma, and there are some that increase the susceptibility or the risk of developing asthma. There are some that increase the risk of more severe asthma, and some that increase the risk of particular driving components of asthma, some of those boxes that I showed you at the beginning. And there are also factors that can worsen asthma control and severity. So behaviors, for instance, like smoking, but also other subtypes of disease are associated with severity, for instance, fungal allergy or aspirin sensitivity, obesity, and then comorbidities like chronic sinonasal disease and psychological comorbidities, and sometimes work-related factors. So it is a complex question to which we are still searching for the answers, and it's the focus of much ongoing research. So this is my final slide, and I've talked a lot, and I hope that it has given you a useful introduction. But one point is that asthma is really common, but most people with asthma can achieve good asthma control. Difficult to treat or severe asthma affects a small number of people, but it has a huge impact. And a careful, structured approach is key to addressing severe asthma, and that needs to look at the whole patient, not just regard them as an asthmatic. And personalized approaches are key to improving severe asthma. And we're very fortunate now that we are in the era where new treatments, particularly these biologic treatments, are offering major benefits for a lot of patients with severe asthma. And I will leave you with one final point, which is that it is possible to live better with severe asthma. That's my talk. Thank you very much.
Thank you so much, Ramesh. That was really great to hear. And I love some of your analogies you've used to describe severe asthma. Now we're going to move on to the video from Hannah. And then at the end of that, we will have some question and answers. So don't forget to pop them in the box.
Hi, my name is Hannah and I'm 23 years old and I'm from Sweden. I was first diagnosed with asthma when I was 5 years old, and during my childhood I had the normal, what you would call infectious asthma, so I only had to take medication when I was sick. So besides that, I was like any other child, could play around, hang out with friends. I played soccer and I did horseback riding and whatever else children did. Then I started to develop allergies when I was around 10, 11 years old, mostly to pollen, dust mites, and animals. But then when I turned 15-ish, when I entered puberty, my asthma got a lot worse. And at first they thought it was mostly anxiety. But then after a severe asthma attack during a PE lesson, I got sent to the hospital to see an allergist and pulmonologist, and then they realized that it wasn't in fact anxiety, it was that my asthma had become a lot worse. After starting omalizumab, the amount of severe asthma attacks I had decreased, so now I only have them a couple of times a year, which is a huge difference, even though my lungs aren't really working as they should, and I am still on a lot of medications, and my asthma is still getting worse and worse. We still think that omalizumab has helped me a lot, and especially during the pollen season and with my animal allergies. So before I still am really allergic to cats, and I couldn't even be in the same room as someone who had a cat at home. But now I can't be at someone's house if they have a cat, but I can still meet them and I can hug them, and that is something that is very good because a lot of my friends have animals. apart from omalizumab, I'm still on a lot of other medications. I still have to take steroid tablets, and we are trying to get me off of them, but it is a struggle. And I take several different inhalers every day, as well as montelukast and theophylline tablets. And in addition to that, I also am on antihistamines and other things for my allergies. But in the bigger picture, my medications do work, even though I still get severe exacerbations when I, for example, have an infection. So I used to be on antibiotics. I was on antibiotics for like 6 months because of an infection, but now finally I'm off those, and that's great. Luckily, I don't have a lot of side effects except for the usual side effects that most people get from steroids, weight gain, and sometimes I have trouble sleeping. I'm considering myself lucky that I don't have a lot of side effects, since I do have to take so many medications. So that's a really good thing, because then it most motivates me to, continue to stay on these medications. Because of my asthma, my life does look a bit different than most other 20-year-olds. I have to remember to take my medicine every single day, because if I don't, I know that I will end up in the hospital. I am a lot more tired than most people my age. I sleep a lot. I don't really have the energy to go out, and I prefer to stay at home and have my friends come home to me. I don't, for example, like to go to the cinema, because I know that there probably will be something there that will trigger my allergies. But with some accommodations, I still can do whatever I want. I just have to think a little bit more and plan a little bit more ahead. And with the help of others, most things do work out. In the future, beside from finishing my medical degree, I have high hopes for new biological treatments that I know are under development, because I don't have eosinophilic asthma, so I haven't been able to try other biological treatments except for omalizumab that I am on now. So both me and my doctor have high hopes that there will be a biological treatment that will work better for me. So that's something that I'm really looking forward to, and I hope will come pretty soon. Most of us are in the community are not seen as sick, but we are, and it can be a struggle sometimes to get people to understand that. So encouraging the patients in that and helping them to be as healthy as possible is very important. And I also think that it is really important to see the whole patient and not just the asthma, because we are much more. And with a healthy lungs, we can do everything else that everyone else can do.
So that was sorry, I was just waiting for it to all sort. That was a really inspirational video from Hannah, just really highlighting the impact that severe asthma has had on her life, but also it shows that she still has hopes and dreams and aspirations for the future. So now we have some time with Ramesh, and there's been quite a few questions have come into the chat and lots of discussions. There's one I was going to ask that I think is probably is quite key to when you were speaking about sort of adherence and the best management and best medication. Is someone has asked, having had various inhalers over the years, I've tended to use the same technique with all inhalers and inhale with the same strength. But when they went outside of the UK and given a different device that had different settings to replicate different inhalers, they were aware that they needed to start using that not all inhalers had the same technique. they're asking, should patients be aware of this, and where to find education about the best way to take your inhalers?
Well, thanks, Olivia. That's a really important point, because one inhaler doesn't suit all patients, and we are, I think, very guilty traditionally as healthcare professionals of just prescribing the familiar device, what we think is best for the patient, but actually they may not be well suited to that. And you're quite right, and the person who's written that query is quite right, that they may have a particular need for a particular inhaler device that suits their individual sort of situation better. So it will vary according to the device, the amount of inspiratory flow that you need, the coordination to use the device. And really speaking, their healthcare professionals that are supporting them should be assessing their suitability for particular devices when prescribing the devices. And I think they're referring to something like the InCheck device, which will enable estimation of inspiratory flow and then suitability of particular devices. And that's the kind of thing that should be standard of care in a primary or secondary care setting for anybody with asthma. So the healthcare professionals should be able to guide them.
Okay. Ramesh, there's first of all, I want to say that there are lots of really good questions, and we're delighted to receive them all. Please bear with us; we'll try to respond to all of them. But Ramesh, there's a couple I'd like to kind of bring together as perhaps as one. A really good question about coexistence of asthma and COPD in people who, especially in people who've smoked. And then if you can link that with another couple of questions that we're focusing on infection, immunity, how can one boost our immune system to help us cope with infections?
Sure. Yeah, great questions. Thank you, Ratko. Yeah, we're very, again, very used to traditional views of lung conditions and saying somebody has asthma, somebody has COPD, that they don't overlap or coexist. And increasingly, we're realizing that life is not as clear cut. Obviously, we link COPD to exposures to risk factors like smoking and biomass fuel inhalation. But what we also know is that asthma actually is emerging as a potential risk factor for COPD. If you look at the life course studies, for instance, the longitudinal cohort studies that have followed people across the life course, you see as people start to get into middle age, development of features of COPD, yes, in people who have smoked, but also in people who have a history of persistent asthma, and particularly more so in people who have persistent asthma and who have smoked. And you can see an accelerated decline in lung function through early to mid adulthood, particularly in that latter group who have asthma and who have smoked. So I think it is an important concept. It may need particular lines of treatment that dip into treatments for COPD as well as for asthma, but it is something I think that we do need to recognize and accommodate in our treatment planning. And in terms of infection, yes, people with asthma are very vulnerable to infections, and part of that obviously stems from, if you like, an inherent weakness in the immune system and a vulnerability and an inability to fight viral infections. And we, of course, in Southampton have been involved in attempts to develop treatment strategies to boost that antiviral sort of weakness and need. But there is also a growing volume of research looking at what we call the airway microbiome and how that might relate into susceptibility to patterns of poor asthma control, and how particular bugs that might colonize the airways might drive that. But that's very much in the research phase at the moment.
And could you maybe just comment on the use of antibiotics like azithromycin, and perhaps the current studies with doxycycline?
Yeah, so we do now have evidence emerging from the research literature to suggest that what we call the prophylactic use of antibiotics day to day may help control in those situations. So azithromycin is a type of antibiotic from the macrolide family, which has been shown to have effectiveness in improving asthma control and reducing what we call asthma exacerbations or attacks from a couple of very nice studies, one which suggested that it was particularly helpful perhaps in particular what we call non-T2 types of asthma, but another study that has gone on to show that it seems to help regardless of the inflammatory subtype of asthma. And we do use those antibiotics in a proportion of patients and see whether they improve the situation. And you mentioned doxycycline there, which we also do use, particularly in people with dual asthma and sinonasal disease, where they get chronic inflammation in the upper airway, nasal polyps, and they may get colonization of the lining of the nose with certain bugs like Staphylococcus, which then act as targets for the immune system to attack. And then by clearing the bugs out of the upper airway, you can actually then start to reduce the drive for inflammation in the upper airway and then reduce the signals to the lower airway.
Thanks so much, Ramesh. I think we've got time for just one more question just now, and then I need to move on for the break. But for people who've posted questions, don't worry, we've got people who are answering the questions sort of backstage, so to speak. You taught in your talk, you were talking about sort of the T2 levels and T2 inflammation. There is a question from someone asking, how does this get measured? How do you find out if you have sort of T2 inflammation or not? Is it blood tests or sputum tests? How's that?
Yeah, very good question. We don't have a simple test that says you are T2 high or not. So we use what we call surrogate markers. So blood eosinophils are commonly used, those cells that I mentioned in my talk. You can also measure them in the sputum from the airway, but there are also other signals of that T2 type, for instance, XL nitric oxide or FeNO, for example, allergy to common allergens, and you need to often take what we call a composite diagnosis of T2 and look at various signals. So if you think back to my presentation, I said that about 80% will show blood eosinophil signals, about 96% will show T2 signals if you look at a range of those players.
That's fantastic. Thank you so much for your talk and for taking the time to answer these questions. For people who we haven't got to, some of these questions will be answered later on in presentations, particularly the ones sort of regarding biologics and treatments. But for just now, we'll just take a break. We'll be returning at 10:40 or UK time, 11:40 Central European time. So we look forward to seeing you all back then.